Hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be a little bit different than most of the talks I've given. This is called Felix 2.0, where we are and where we are going. And you may ask, what's Felix 2.0? Well, that's the work we've been doing on early detection of pancreatic cancer. And I thought I would like to speak to you, tell you what we've been doing, we've been looking at, and what the problems are. So even though I'm looking only at pancreatic cancer, I'm using pancreatic cancer as a disease state that we all know the challenges with and how AI might be helpful in what things we're looking at doing. So let's take a look a little bit at the background of the story. So the goal is very simple: earlier detection of pancreatic cancer. The word early, I don't know what that means exactly. Earlier would mean to us that at a time when patients could have surgical intervention and potentially be able to be cured. If you pick up disease early, stage 1, even up to stage 2, survival at 5 years reaches 60 to 70%, where currently survival has moved all the way up to 13%. Now, to let you know and to give credit to other people, at Hopkins, I'm actually the PI for this project. Linda Chu, Satomi Kawamoto are two of the key people with me in terms of radiologists. Then we have a number of people in our lab working hard, and we work closely with pathology and surgery and oncology and medicine. We also work with Microsoft AI for Good, Juan Ferez and his team, and the Lustgarten Foundation out of New York, which supports pancreatic cancer research from the molecular level on up, is our main supporter for our faculty and our research people. So I want to thank all of them for making this possible. Now, just a few comments about AI. This is an article we published in JACR recently. Access to data is one of the biggest challenges we face. There is a significant amount of data that cannot be open to researchers because of privacy issues, especially in the medical world. So this becomes very important to us. We have spent literally about 6 years gathering cases, mainly Hopkins cases, and we've now segmented over 3,000 pancreatic cancers, thousands of other tumors, including neuroendocrine tumors, well over 1,000. We've also looked at a couple thousand normal patients, potential renal donors. So we've put a lot of effort in building our library. Of course, one of the things you would like is to have even more cases done on varying scanners, a different range of population. We have a very varied population because patients typically go to big cancer research centers like Hopkins from all over. So in some sense, you have a diverse population, but it's never diverse enough. So one of the things we need to do, of course, is make certain we have enough cases. The NIH is working on a way of collecting cases, de-identifying them, and making them available. I think regardless of the topic in AI, one of the biggest challenges is getting enough cases. People have done all sorts of things to try to get around this. Federated computing, Microsoft differential privacy platform. Again, how can we share data without worrying about HIPAA violation? That article also makes the point, contrary to popular media speculation, AI alone is not enough to overcome the problems that society seeks to resolve. Machine learning depends on subject matter experts to find solutions. And so when we look at radiology, to improve diagnostic certainty, suspicious case identification for early review, better diagnosis, and a quicker turnaround, it's really a combination of expertise in machine learning with radiologist expertise and the convergence of AI and radiology to provide the best outcomes for our patients. Now, there was a fantastic article in press just now by Matthew Lundgren, who's actually a radiologist trained at Duke, went to Stanford, and now he is one of the senior people at Microsoft and at Nuance, making the point about understanding data, text, imaging, genomics, and the like. He talks about the ability of things like GPT-4 to be able to analyze this data. The ability where a future where systems grasp context across modalities, revolutionizing healthcare data interaction and patient treatment. So one of the things Matthew is very clear about is we're developing new technologies that will make our job easier. In the new biologic AI paradigm, punctuated by large language models or LLMs, more is different resonates once again. As LLMs scale in terms of the amount of data they are trained on and the complexity of their architectures, they begin to exhibit emergent behaviors, capabilities that are not explicitly programmed into them. This manifestation of emergent behaviors in LLMs underscores a profound interconnectedness between the realms of natural and artificial complex systems, echoing Anderson's seminal insights into the nature of emergence and complexity. The bottom line is that things are changing and they're creating opportunities for us. We need to take advantage of the opportunities, and that's what we're trying to do. Now, this was an article from Satomi Kawamoto, or it's an article coming out in abdominal imaging. This was an RSNA exhibit looking at why things are missed. So just a few points to remember with pancreatic cancer. Third most lethal malignancy, 5-year survival, it's now 13%, is the lowest 5-year survival of any solid malignancy. Early detection is critical. However, we're not good at early detection. Abnormalities detected in up to 42% of imaging studies less than 5 years before clinical diagnosis of PDAC has been shown, which means we're missing a lot of cases. But the flip side to that is we have the opportunity, if we could do better, for earlier diagnosis. So we looked at some of the easy misses. What are the things that all of us miss? Small isoattenuating or hypoattenuating masses without contour deformity. Remember the rule, under 2 cm, 40% are miss. Under 1 cm, it's higher than that. But it's easy to miss subtlety. Pancreatic duct dilatation with or without cutoff, that's the most common secondary finding. Remember our rule, and I think this one we're better at. If you see a dilated duct but can't explain it, you need to do EUS. You need to do another study, MR perhaps, or EUS, because one of the key early findings is a big duct with duct cutoff but no obvious mass. Invariably, there is a mass present. Yes, I've seen a few cases of benign strictures, but the high propensity of patients are going to have a small tumor present. We talk about things like focal loss of the normal contour, loss of fat, loss of the feathery pancreatic contour. We have challenges when PDAC arises in a patient with prior pancreatitis, particularly chronic pancreatitis. We have problems when pancreatic cancer is an incidental finding in a trauma case or a case of diverticulitis, or where it's not the primary diagnosis. Again, we look at the pancreas, but people will miss subtle findings. And again, technique is everything. If you want to see pancreatic cancer, you need thin sections, and ideally, you need dual-phase imaging. Small PDACs without contour abnormalities, again, commonly are missed. Small PDACs can be difficult to detect on CT, especially when they tend to be isodense. In this article by Kang, significant number of missed PDAC findings were small lesions, isoattenuating lesions, or when there was no contour deformity. So we know what we have to look for. By doing that, I think we all could do better, but I think also it's what we need to train the computer on. So here's just a couple examples. Top line shows a lesion, very, very subtle in the pancreas. It's nearly isodense. I'm not calling that top lesion, but there it is 9 months later, and you can see the lesion is obvious, and it has vascular encasement. So that early lesion would have been resectable. 9 months later, it's not resectable. But what a difficult call. It's there. When you look at that, the third image on the first line, you can see the subtle low density changes. But would you call that? I would have missed it. Here's another patient where the patient has an isodense PDAC on the venous phase. It's better seen arterial phase, and it's better seen delayed phase when it's hyperdense. This was a case where the question was a right renal mass, and you can see the patient has a renal cell carcinoma, which explains the multiple phases. But look, as you go across the bottom line of those 4 images, look at that subtle 1 centimeter lesion in the body of the pancreas, seen best probably on arterial phase, hard to see or impossible to see almost in venous phase, and delayed phase imaging shows it nicely, but interesting as a hyperdense rather than a hypodense lesion. So a real challenge. I mentioned pancreatic duct dilatation. It's the other critical finding. Again, yes, you can have a dilated pancreatic duct, and you can have an IPMN, a main duct IPMN, but you worry about that having high-grade dysplasia. But if you see a duct with a duct cutoff, yes, it can be old trauma, yes, it can be pancreatitis, yes, it can be a stricture, but you have to exclude pancreatitis. You need to do additional imaging, and the EUS is usually what's done with a biopsy to confirm or exclude the presence of a tumor. And here's a nice example, the initial CT. There's a dilated duct which stops in the body of the pancreas. You don't see an obvious mass. The 4 months later, the mass is there. On the first scan, it's easily resectable. The second scan is going to be more difficult. But in 4 months, look at the change. Look how much larger it is and how much more obvious. On the other hand, if you follow the rule, there's a dilated pancreatic duct, let's look into it, you're going to do better. So what things do we recommend? High index of suspicion. Patient has abdominal pain, or any patient you're looking at over age 40, look very carefully at the pancreas. Don't just pass it by. Look for some of the early signs. Look at the vessels nearby, and that's a good rule on all cases. For equivocal cases, consider dedicated pancreatic protocol or MR, or even EUS. If you think there might be something there, just repeat the study. In patients with acute or chronic pancreatitis, you want to look very carefully, recognizing that that's going to be a really difficult case. And again, to detect early PDAC and maintain a reasonable degree of specificity, not to overcall and have a million false positives, we're going to need to do things better. Doing it the way we do it now just is not going to work, because if I'm going to really pick up all of those very tiny lesions, I'm probably going to have to do a lot of overcalling as well, which in it of itself is a challenge also. So what things can we do? Well, one of the things is 3D mapping to visualize the volume of the gland rather than just slices. It can help accentuate tissue differences rather than just looking at a mass. And cinematic rendering is particularly good for looking at textural change. Simple example, you should see this on the axial. There's about a 2.5 centimeter mass in the tail of the pancreas, hypodense, and there it is very nicely shown on the patient's cinematic rendering. There it is on the cinematic coronal view, even easier to see. Again, notice the change in texture between normal and abnormal pancreas. And here's another example, pancreatic adenocarcinoma. You see the duct cutoff right there? There's the subtle mass, which is accentuated a bit on the cinematic rendering. Again, here it is on the coronals from the initial study. The lesion is there, you should see it, and that pancreatic duct should lead you right to it, but this was missed. But if you had the cinematic, perhaps you would have seen that very obvious change in texture in the middle of the body near body-tail junction, and you would have been able to call it a pancreatic cancer. And here it is again on the coronal view. So one of the things we believe cinematic rendering can do, particularly if we can automate it, perhaps with AI, is pick up subtle textural changes, things that we might miss very subtly present on routine CT. Another example, this was missed. There's a subtle lesion in the head of the pancreas right there. Well, if you look at it, it's there. It's there. And there it is on the cinematic rendering right there. Here it is on the coronal view. very nicely shown. And again, with cinematic rendering, we're talking about volumes, not looking at axials or coronals, but looking at volumes. And it's easier to see changes in texture in a volume. So you can see the lesion very nicely there. Another example here, a little more obvious, dilated pancreatic duct, mass in the body of the pancreas. Sort of classic again, and very nicely shown in the cinematic. You can see there's atrophy of the body and tail of the pancreas, which is common, dilated duct, but here the textural changes are particularly impressive. And again, on the coronal volume rendered with cinematic rendering, there's the cutoff right there, there's the tumor, there's the patient's dilated pancreatic duct, all very nicely shown. And here I'm accentuating the texture of the patient's pancreatic mass. Now this takes time, it takes experience. Can AI do this? We hope the answer is yes. Now, we've written several articles on cinematic rendering. This article talks about how it's a novel tool for surgical planning to really define the tumor as well as the vascular map. So it goes beyond detection into patient management. And again, if we could do cinematic without physician intervention, it might be ideal because people are looking to do less, not more these days. And if you want to do it on every patient over age 40, it's probably not going to be realistic to expect a radiologist to do it or a tech to do it. You're going to need to somehow automate the process. Now, the next thing I want to speak about in terms of detection, and this now focuses more on the classic AI and work we've published on, is radiomics, which is a way of looking at the data and getting fingerprints or signatures from the data. We're looking and getting information that the user can't see just by simply looking. But what we'll do is, because of the time, let's take a break here and come back and start with radiomics. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.